Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is an intermittent cataract with high intralenticular pressure. Now let us think why it happens, why the intralenticular pressure increases in cases with intermittent cataracts. When the cataract becomes mature, the lens proteins act as solute, and we have studied in our higher secondary curriculum that when two solutions are separated by a semi-permeable membrane, water molecules from lower concentration moves towards the solution with higher concentration through the semi-permeable membrane. This is what happens in intermittent cataracts. The lens proteins act as solutes and they are in higher concentration because the water molecules inside the lens is less, whereas water molecules inside the aqueous is much more. So as the lens capsule acts as semi-permeable membrane, water molecules from aqueous humor moves through the capsule into the lens where the solutes are in higher concentration. Thus they try to get an osmotic balance, but in this process lot of fluid collects inside the lens and the intralenticular pressure becomes high. And as soon as we make a puncture on the anterior capsule, the punctured site may run to periphery, thus causing a Argentine flag sign with blue on two sides and white in between. But if we do in this way, and if we do a small rhexis first and aspirate the cortical lens matter in this way, the intralenticular pressure decreases and the cataract behaves in a completely different way after decreasing the intralenticular pressure. In this case, the mini rhexis has been already done, some superficial cortical lens matter has been aspirated, and now with the help of a Vanna scissor a small cut is made at the margin of the mini rhexis. The Utrata forceps is taken again, and this is how you enlarge the rhexis. At this time there is no tendency of the capsule to run to periphery. So this is a nice technique to do capsulorhexis in intermittent cataracts. In Phacolytic glaucoma, the mechanism is completely different. There the lens capsule has become more permeable. Some low molecular weight as well as some high molecular weight proteins can leak through the capsule and come into the anterior chamber. What I am trying to say is it's a completely different type of capsule in Phacolytic glaucoma, where the capsule has changed its character. In intermittent cataract, the capsule is a semi-permeable membrane, and in Phacolytic glaucoma, the capsule is more permeable to lens protein molecules. The lens protein molecules come through the capsule into the anterior chamber, and ultimately they block the trabecular meshwork and can cause Phacolytic glaucoma. In intermittent cataract, the swollen lens can cause pupillary block. There can be peripheral iris of Bombay, and thus there can be Phacomorphic glaucoma. So in intermittent cataracts, if not treated in the right time, it can cause pupillary block, peripheral iris Bombay, and Phacomorphic glaucoma. In Phacolytic glaucoma, the antechamber depth is normal. The capsule has become more permeable. Lens protein molecules pass through the capsule, come into the anterior chamber and block the trabecular meshwork. So to separate characters of the lens capsule in two different situations. In intumescent cataract, the capsule acts as a semi-permeable membrane, and in phacolytic glaucoma, the capsule acts as a more permeable membrane where the lens protein molecules can pass through it. So in this case, the nucleus has been managed by this time. Now the cortex is being cleaned with the help of a 23 gauge Simcoe cannula. The Simcoe cannula is working through the right side port at this time, and now it goes through the left side port, and cortical matter is removed. But see, in this case, lot of cells are sticking to the posterior capsule. It happens in some cases with intumescent cataracts. So what to do now? You take the irrigating probe, and with the help of the irrigating jet of fluid, just gently rub over the posterior capsule and dislodge these cells. And I am going to remove these cells by the back mode, capsular vacuum mode of the phaco machine, that is by IA2, where the vacuum is only 50 mm of mercury and flow rate is 25. So 25 ml per minute flow rate and 50 mm of mercury vacuum. This has been used to polish the posterior capsule, to remove the cells that was sticking to the posterior capsule. And now in this case, we are going to implant a beautiful lens from Hoya, Japan. It has got a beautiful preloaded system, and the device can go through the 2.8 mm incision. The tip of the cutis can go through the 2.8 mm incision. The incision need not be enlarged. It goes easily through 2.8 mm incision into the anterior chamber like this. And this there is a screw device. Hold the cartridge with left hand, screw with right hand, and the lens goes into the capsular bag. In this case, the leading haptic has gone into the capsular bag. The trailing haptic is still not in the bag, so I use a Sinskey hook, press the trailing haptic, and it goes into the capsular bag. And now the lens is in the capsular bag. It is oriented in this direction. The haptics are at 2 o'clock and 8 o'clock. And now the visco has to be cleaned very nicely. First, I irrigate for some time, irrigate both the capsular bag and the anterior chamber for about 1 minute, and this will cause removal of most of the visco. We must dedicate some quality time for removal of visco so that post-op rise of intraocular pressure doesn't occur. If there is retained visco, it can cause raised intraocular pressure in the postoperative period, and we have to treat that medically. The patient will be unhappy. So better to give some quality time at this moment and avoid the post-op rise of intraocular pressure. This is the irrigating probe. It is being used to irrigate the capsular bag as well as the anterior chamber. And now irrigation and aspiration is being used together. So I have dedicated about 2.5 to 3 minutes for removal of visco. So we must be meticulous in our surgeries. We must dislodge the cells on the posterior capsule, irrigate and aspirate, do it in cap back mode, the capsular vacuum mode of the phaco machine. We must remove the visco very clean, very nicely. If we have used visco for implantation of intraocular lens, so we must dedicate some quality time for the patient to do a nice surgery. You cannot just hurry up. and this is the final lavage with a pure basis. I inject moxifloxacin. Most of the moxifloxacin is washed out, but whatever remains behind the IOL is enough to control infection. The integrity of the wounds are checked, few drops of mox is applied, and the case is concluded. Thank you very much for your attention. This is a totally unedited recording of the surgery. Hope this will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.